Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this 11th edition in webinar series Practice Pulse in Hypertension. Exactly a year ago, on 11th July 2020, we have started this journey of learning important concepts in managing hypertension. Initially, we thought that it would be difficult to run a webinar series only on hypertension to such long. But under the apt guidance of Dr. J.C. Mohan, we were successful in conducting 10 sessions on 20 different concepts. And today, we are again live with two more interesting topics: episodic hypertension and impact of hypertension on sleep. And to moderate today's session, we are having with us our course director, an encyclopedia of clinical research conducted in the field of hypertension and cardiology, and his keen interest in research resulted in more than 250 research papers to his credit. We are fortunate to have with us our course director and moderator for today's session, Dr. J.C. Mohan sir. He is currently a chairman and head of Department of Cardiology at Jaipur Golden Hospital, New Delhi. So without further ado, I hand over digital podium to Dr. J.C. Mohan. Over to you, sir.
Thank you, Dr. Mithilesh. I am also happy to see two stalwarts of different super specialties. Dr. Narsingh Verma, who is a foremost leader in the field of hypertension in this country, and he comes from Lucknow, and of course Dr. J.C. Suri, who is the chair of pulmonary critical and sleep medicine at Fortis Hospital, Basant Kunj. It is a great pleasure indeed to have our experts, as I was just talking a few minutes back, Dr. Ashraf and Dr. Manish Bansal, the generation, the cardiologists of the generation of which we can be proud of. The two extremely talented people of a slightly different age group, but I'm sure that their experience, their skills, their talent matches anybody in the field. Hypertension, we have been discussing now, as Dr. Mithilesh was saying, for the last 10 webinars. It is a major public health problem. You saw the slide, more than 200 million Indians, probably about 250 million adults have hypertension in this country. We have extensive data from the 4th National Family Health Survey published in Public Library of Science in 2019, showing about 21% prevalence of people above the age of 18 years. And which would actually end up saying that we probably have 225 million people with hypertension, but those are the guesstimates. The big issue is that the awareness control is dismal, the treatment is dismal, and we have a ways long to go before we can say we may have any handle on hypertension. Forget about having a control of hypertension, which in US about 57% this year, and we are probably struggling below 10%. There isn't any doubt there is a lot of things which we need to do. And of course, the issue that there are many facets which are not discussed, but they all affect a clinician, and the clinician keeps wondering, why do we keep talking about hackneyed things about hypertension, resistant hypertension, refractory hypertension, hypertension in pregnancy, drugs for hypertension, primary hypertension, secondary hypertension, and of course the new phenotypes hypertension. Why not go beyond that which encounter? And one of the topics which we recently I think of great importance, episodic hypertension, and I'm extremely pleased that Dr. Narsingh Verma has agreed to speak on that. The other, of course, is closer to our heart, and of course, we have a long road to cover before we can actually do something about the effective management of sleep disorder related hypertension. which probably accounts for the sleep disorders are associated with hypertension 50%, or you could say people with hypertension 30 to 40% of them have sleep disorders. We wouldn't obviously call it only obstructive sleep apnea. Interesting data, interesting observations, interesting epidemiologic study, and none other than Dr. J.C. Suri would take us through that. So without taking much of your time, let us talk about episodic hypertension, and I invite Dr. Narsingh Verma, who is professor of Department of Physiology and head of the Family Medicine, King George's Medical University, a foremost leader, and he has been the president of most of the hypertension-related associations of this country and in Asia-Pacific region. I don't want to stand between him and you, Professor Verma.
Thank you. First of all, I would like to thank Course Director Dr. J.C. Mohan for giving me this opportunity to talk about the topic which is very close to my heart, I will say. And I will also like to thank the organizers for giving this opportunity to talk about episodic hypertension. That reminds me that in one of the meetings, when I was talking about the home monitoring, and I told the audience that during my lecture in KGMC way back 20 years back, and there was no AC and no the system, loudspeaker, other systems, audio visual systems, and 250 students, we have to shout and we have to compete with the noise level which was there by the old fans. And at that time, when I told that, at that time my ABPM reading showed that during my lecture, my blood pressure rose to 180/110. Then the audience reacted, no, this is not possible. So at that time, I thought that it's very difficult to talk about episodic hypertension to the physicians because they really do not admit that it happens. So not wasting much time, I start sharing my slides and yeah. So I will start with the slides, and it is the episodic hypertension. And in the episodic hypertension, blood pressure, we know that blood pressure varies. And this variability of blood pressure is not related to blood pressure only. This variability is the law of nature. Everything varies, and that is what chronomedicine and chronobiology is. And I'm working in the area from last 15 years. So I can say that blood pressure is one variable which is very variable, and that variability is also important physiological, but sometimes it becomes troublesome. Similarly, heart rate variability. And we know that the variability of heart rate is very much required, and that take care of the variability which is going to occur in blood pressure. If heart rate variability is not there, then the blood pressure does not vary, and that does not accommodate that, and that becomes very, very dangerous. So blood pressure normally varies in response to various stimuli. That can be physical activity, that can be experienced in the emotions, and postural. We know that postural changes in the posture, supine position, sitting position, standing position, blood pressure keeps on changing, and each cycle of respiration, during inspiration, expiration, blood pressure is not same. And in the time of day, in the 24 hours, we have two peaks, and blood pressure keeps on varying. And we know that during midnight, when we are sleeping, blood pressure goes to very low levels, and just before rising, it goes very high. And again, the peak occurs in the daytime, at the time of the, you can say, the evening, again the peak occurs. So there are usually two peaks, and on that basis, we decide that whether the patient is having dipping pattern or non-dipping pattern or supra-dipping pattern or the reverse dipping pattern. That is the daytime variability or 24-hour variability. And it also varies with food ingestion, taking salt, not taking salt, caffeine intake, use of nicotine, alcohol, and sleep deprivation. A single episode of sleep deprivation had its effect up to 1 week, that is known. So that is one area, and also seasonal variation. During winters, blood pressure goes high, and during summers, it goes down. So this is very, very important. because we have to adjust drugs, the same person during summers and winters, and of course high altitude do alters the blood pressure. So the variability can be short-term variability, ultra-short-term variability, minute-to-minute variability, week-to-week variability, hour-to-hour variability, day, intra-day variability, hour variability, week variability. Monday is not Sunday and Sunday is not Wednesday. Every day blood pressure remains different. That is why in most of my ABPM studies, I go for 7-day monitoring, not only for 24-hour monitoring. That is one issue in ABPM. ABPM requires whole 7-day because all the 7-day have different activities. So short-term variability, long-term variability, visit-to-visit variability, seasonal variability, all these variabilities are there. And this slide shows that approximate increase in systolic blood pressure occurs after each variability. A psychological stress can increase blood pressure the tune of 20 to 60 millimeter of mercury. That is the example which I was talking to my audience during that meeting in Delhi. And some of my physician friends laughed it and said, Professor Verma, kindly reduce it. Don't say 110. 110 is always hypertension. You say maybe 10 millimeter mercury high. So that I'm showing even 60 millimeter mercury change can be there by psychological stress and anger conflict. And during sexual intercourse, blood pressure again goes up to 20 to 60 millimeter of mercury. And major physical exertion like running, lifting, doing some job and physical work, again the blood pressure goes the tune of same 20 to 60 millimeter of mercury. Major the pains, different type of pain, they can also arouse and can increase blood pressure the tune of 20 to 40 millimeter of mercury. Waking up from sleep early morning, blood pressure goes high, 20 to 40 millimeter of mercury. Mid-morning surge, again in the same tune, and driving to increases blood pressure at the tune of 10 to 20 millimeter of mercury. Driving stress and postural changes, sweating, etc. during physical activity, blood pressure again goes to 10 to 20 millimeters of mercury high. And anticipation of major physical exertion. Just anticipation at the cerebral level, at the level of thalamus, hypothalamus, at the level of that, the perception that we have to go for that, the blood pressure rises. Even thinking of exercise increases blood pressure at the tune of 5 to 10 millimeter of mercury. Minor physical exertions, dressing, walking, all these again have a change, and the ambient temperature, change in temperature also increases blood pressure. All these issues are very important when we are measuring blood pressure because we have to think of all these issues. And eating do increases blood pressure. Smoking, tobacco use of any kind, because smoking is the Western word. In India, tobacco is used. 11 types of tobacco users are there. Even some patients are using tobacco pillow. So that is a variability in use of tobacco again in Indian population. They can eat tobacco, they can smell tobacco, they can chew tobacco, and they can smoke tobacco. They can use tobacco in every form which Western world has not think of. Telephone call even can increase blood pressure, and distended bladder, full bladder, 10 millimeter of mercury. That is why we advocate that before measuring blood pressure, one had to empty the bladder and bowel both. Alcohol use and coffee again make a change in the blood pressure. Medium term, days to month changes are occurring in underlying systolic blood pressure, and that can be chronic psychological stress, financial, emotional, work related. All these can change the blood pressure the tune of 10 to 20 millimeter mercury. And climate season change, which I was talking about during the summers and during winters, the tropical country like India, this is very, very important because we have all the 4-6 seasons within 1 month. So that can create a change in blood pressure. That is why more monitoring is required in the Indian population. The same drug may not be true for the next month. So that is very important in our setup. In intercurrent infection, various infections, viral, bacterial, during this COVID times, I have witnessed, and my colleagues have also witnessed, you all have witnessed that blood pressure goes down. Most of the patients who were given treatment for hypertension, now their blood pressure is low. Up to 3 months, 2 months, 4 months after COVID, blood pressure is still low. So they do not require any drug for that. So that change can occur during infections, after infections, and before infections when it is going into the body. Increase in body weight, BMI change will definitely have an impact on blood pressure. Increased alcohol intake, decreased alcohol intake, shift work. Shift work is one area. Most of the chronobiological studies, chronomedicine studies, some of very good studies we have done in our laboratory in KGMU, shift work studies. You can find it out at ResearchGate if you want to see it. Depression do alters blood pressure in the tune of 5 to 10 millimeter of mercury. Menstrual phases, different menstrual phases, premenopausal, postmenopausal, during menstrual phase, and different phases have different blood pressure, and the change can be in the tune of 5 to 10 millimeter of mercury. Salt intake if decrease, that can decrease blood pressure in the tune of 5 to 10 millimeter of mercury. DASH diet has shown that by using DASH diet, adopting DASH diet can reduce blood pressure in the tune of 5 to 10 millimeter of mercury. And the regular exercise can again have a change, but regular exercise for some time, not acute one. The chronic effect is that blood pressure can go down the tune of 10 millimeter of mercury. Stopping smoking, just stopping tobacco, can change blood pressure in the tune of 10 millimeter of mercury. So all these factors are responsible for the variability which we are discussing from last 5-10 minutes. So episodic hypertension, what is it? If patient experience recurrent and substantial, recurrent is very important, not a single episode, and substantial, not 2 millimeter of mercury, 5 millimeter of mercury, substantial, transient, not a constant one, transient elevation in blood pressure. Frequently, but not always. Reading above 160 millimeter of mercury should go beyond that, or maybe even less than that. That is called as labile or episodic hypertension. If you go to medical dictionary, you will find a different terminology. Episodic hypertension has not been clearly defined by the medical dictionary. They refer it episodic hypertension during the spinal cord injury, SCI, that creates a lot of changes in the sympathetic nervous system that do produces episodic hypertension. Patients usually associate their elevated reading with stress, and they usually say that that particular incident is responsible for all this illness, and that has caused this hypertension, and they're emotionally attached to that, and they talk about emotional distress. All the elevations can also occur without the provocation, because they have certain physiological changes within the body. Various mechanisms which are there to control blood pressure, to elevate blood pressure, if they become potentiated, the blood pressure goes very high. Blood pressure elevation is usually asymptomatic in beginning, but can be associated with symptoms such as palpitations, flushing, or headache. So these three symptoms can be there, or a few other symptoms can be there, but usually in beginning there are no symptoms. So there is no quantitative criteria to define or diagnose episodic hypertension. The diagnosis is largely clinical diagnosis, and this clinical diagnosis term is almost extinct in my country, in all over the world. Now the medicine is changing very fast. Now most of the time there are lot of investigations and clinical diagnosis is done. So what is pathogenesis of episodic hypertension? Episodic hypertension pathogenesis is again very physiological, and various humoral factors like angiotensin 2, which is involved in long-term regulation of blood pressure, bradykinin levels, endothelin 1 secreted by the endothelium. We know that endothelium secretes almost 115 type of hormone-like substances, and most of them are vasoconstrictory in nature, and that is led by endothelin 1. And some of them are vasodilatory in nature, which is led by nitric oxide. Insulin does have the impact, and triglycerides do have the impact on that. So that can produce episodic hypertension. Baroreflex failure, we know that baroreflex activity is the most important, most fast activity to change about blood pressure. If that activity is blunted, then blood pressure change is not following that, and that can create episodic hypertension. Reduced arterial compliance with age, that happens because the compliance goes because the elastic tissue goes down and fibrotic tissue increases. And not only that, extrinsic factors like noise pollution is very common in my country, pressure horns, and a lot of high pollution type of noise producing substances, physical activity, sleep deprivation, again very, very common. The India has not slept well from last 50 years. Sleep depriving country India is, because everybody is working in the night and sleep is deprived. Dietary sodium and less potassium, less calcium, less magnesium, not only increase sodium. We talk more about sodium, but the calcium, magnesium, and the potassium is also very, very important. Behavioral factors like mental activity, emotional status, that is very, very important to create episodic hypertension, and various lifestyle factors like lack of physical activity, alcohol, and smoking. This is the baroreflex failure which can occur at the level of the nerves, vagus nerve, or the sometime it may have preganglionic or ganglionic or postganglionic effect. That may be that the baroreceptor activity which is being aroused at the baroreflex or the aortic baroreceptors may not go to the NTS or the center. And this may be because of the parasympathetic and sympathetic dysfunction, which is very, very common in diabetes mellitus. Or there can be some defect in the afferents, and that is possible that from the center the vasoconstrictive effect which should come is altered, and that can produce the baroreflex failure, and that may be because, and that is the cause of the episodic hypertension. And we know that various vagal efferents, they are important for that. And we also know that most of the time, the minute changes in blood pressure, beat to beat changes, change in the posture, change in the various physical activity, they are augmented by the baroreflex activity. And we know that baroreceptors firing level goes on changing every minute, and that change creates change in blood pressure. If that activity is blunted, then definitely elevated blood pressure can be seen. In the long run, the angiotensin II and renin activity will be having impact on the same nucleus, and that can produce changes. So all the mechanisms which are important for maintenance of blood pressure, regulation of blood pressure, maybe short-term regulation, ultra-short-term regulation, or the long-term regulation like the fluid balance and the renin-angiotensin RAS system, all have a role in the producing the episodic hypertension. The selective baroreflex failure can occur, and that can be because of the calmness. We know the blood pressure goes down, the heart rate goes down, and the arousal increases blood pressure and heart rate. And the non-selective baroreflex failure, the same thing, that calmness produces changes in the blood pressure, heart rate goes down, and the arousal increases blood pressure. So we can have both type of baroreceptor or baroreflex failure, and that is one very important area which regulates blood pressure. If that failure occurs, then this is the most important cause producing pathophysiology behind episodic hypertension. If we talk about epidemiology, available data support that the prevalence of this condition increases with age. As the age rises, the episodic hypertension goes high and is lower in young and middle-aged females than males. It is lower in females than males. Advanced age over 60 years contribute to frequent, short-term, symptomatic, spontaneous fluctuations of blood pressure. Every word is important here. More than 60 years contribute to frequent, short-term, symptomatic, spontaneous fluctuations of blood pressure linked to heart rate disorders. That rhythm disorder becomes more common because the SC node becomes old, and lot of changes can occur there, and that can produce the different type of rhythm disorders and anxiety and depression. That becomes more common. More cautious level, more anxiety and depression. Episodic hypertension is more likely to occur among anxious patients and patients under acute stressful condition, again having impact on the hypothalamo pituitary adrenal axis, and that can produce changes in the blood pressure as well. Clinical presentation is very important because all this talk which I was talking about is only the background noise. the basic thing, how the physicians will find it out, and what is the clinical scenario where they will suspect that it is episodic hypertension. There is a recurrent episode. Again, it is very important, recurrent, not a single episode. A recurrent episode of transient blood pressure elevation. If the blood pressure remains high for a very long time, then it is not episodic. Episodic is transient elevation, and it should be recurrent. And blood pressure elevation can be substantial as well. Can be accompanied by symptoms such as headache, palpitation, and flushing, which I talked about in the beginning, and alerting phenomena. This is the alerting phenomena that if not something is not done, then this can create lot of problems. Home BP monitoring is the best way to diagnose episodic hypertension. Although I will say that the gold standard is ABPM. But again, the problem with ABPM is that ABPM in my country, I do not agree to that. It's done for 24 hours. I am doing ABPM in my laboratory from last 15 years, and I have some original data from India that again confirms that ideal ABPM should be done for 7 days, Sunday to Sunday, or Sunday to Saturday, or any day to another day. 7 days at least, because every day our emotional stress and physical stress, our different activities are entirely different. Without noticing them, we cannot say that a person is having hypertension. But because of all the difficulties, 7-day monitoring and troublesome, cumbersome ABPM, that is why the best way India is doing only 24 hours. So 24-hour ABPM is nothing, because it will not rule out the white coat effect, because white coat effect will last at least 1 day. So in 7 days, 1 day is last in that, rest 6 days reading are more important. So home monitoring is the next option, and then the best option to diagnose is the episodic hypertension. Home monitoring is the optimal method for assessing blood pressure variability. Gold standard is ABPM, no doubt about it. And in case of episodic hypertension, frequent heart monitoring, which can foster anxiety and limited reading, should be discouraged. Here, the main important thing is here in this particular slide, that in home monitoring, again, we have to teach our patients and educate our patient that do not measure blood pressure very often. No, I stressfully say to my patient, no, blood pressure measurement should not be done in an emergency. No, not at all. Blood pressure diagnosis of hypertension is based upon one morning reading just after getting up, within 30 minutes of getting up, and after the bladder and bowel has been cleaned, and then one can have the 2 readings at least in the morning and 2 readings at least in the evening. Then only the variability can be noted upon. But episodic hypertension will be diagnosed when the patient feels something, then has to be done. But very frequent, every half-hourly blood pressure measurement will create a lot of anxiety regarding measurement, and a wrong diagnosis will be made. Potential cause of episodic hypertension is episodic life stress and panic disorder. Very, very common panic disorder. Autonomic crisis, which is again related to panic disorder. And again, I will be referring about the hypothalamo-pituitary adrenal axis, and borderline hypertension again may present like the episodic hypertension. Auscultatory gap while measuring by the mercury manometer, which is not very prevalent method nowadays, even by the LED method, again the auscultatory gap can be seen if we are doing it manually. And pheochromocytoma is a clinical condition where the episodic hypertension may be found. So diagnosis is usually clinical. We do not have any test for that, and that is good, because diagnosis should be clinical. It should not be based upon only an investigation. Of course, we are treating the patients, not the investigations. Excessive variability in blood pressure with episodes of substantially increased blood pressure, that is the diagnosis, and it is a clinical diagnosis. differential diagnosis, what you have to kept in your mind, have to be kept in your mind, that is the pheochromocytoma is number one. Paroxysmal hypertension and disorders, hyperthyroidism, cluster or migraine headaches can also behave like that. Acute coronary syndrome, again, very, very important, we have to keep in mind. And renovascular hypertension, again, has more variability. Even in renovascular hypertension, we can see the reverse tipping pattern and seizure disorders again, and drugs, various drugs can produce this type of condition. The pheochromocytoma. Pheochromocytoma differential diagnosis, we have to differentiate. Classical symptoms are headache, intense and global headache, which is not in episodic hypertension normally, and in 80% of the patient this particular type of headache is seen, and palpitation and diaphoresis, again a symptom which is seen in pheochromocytoma, almost around half of the patient, more than half of the patients. Secondary hypertension, adrenal incidentuloma detected by screening in patients with predisposing syndromes, then we have to be very, very cautious regarding this. Biochemical testing for pheochromocytoma can be done, and that's the good test is 24-hour urine catecholamines and the metanephrines. Sensitivity is shown here, the 88% sensitivity, but 99% specificity. While plasma metanephrines have more sensitivity, but specificity is less. So we have to keep this in mind while advising the urinary catecholamines or metanephrines. Then to confirm diagnosis, imaging can be very helpful in the form of CT MRI and the MIBG, PET CT with the differential tracers can be used. Approach to pheochromocytoma, if we are suspecting pheochromocytoma, then plasma-free metanephrines or 24-hour urine metanephrines and catecholamines can be done. If they are normal, then we have the clinical suspicion is still clinical suspicion is high. Then we can repeat test, and if test is negative, then very unlikely the patient is having the disease. And if they're normal, again the clinical suspicion is low, and the patient may not have the disease. Repeat test is positive, then radiological imaging is done, and that is CT MRI is done. The concerns for metastasis are seen, and the functional imaging can be done. And if the elevated, if the plasma-free metanephrines are elevated in the upper limit of normal, more than 2 times the upper limit of normal, then consider interfering drugs. If there is no drugs, then again repeat test if it is positive, again the same line of treatment. If the drugs, some drugs are, patient is taking some drugs, then discontinue drugs for 2 weeks and retest biochemical parameter. So this is the approach, gold standard approach, which is usually done, and it is very, very simple approach and can be easily implemented. Paroxysmal hypertension. We can very differentiate between the paroxysmal one and the labile one, that is pseudo pheochromocytoma, another term used for that. Labile one can be asymptomatic or symptomatic, while the paroxysmal one is markedly symptomatic. And labile one has usually triggered by a stressor and accompanied by emotional distress experienced by the patient, and patient usually links the blood pressure and elevation to emotional distress. And patient usually in paroxysmal one usually appears out of the blue without antecedent emotional distress. So that is in the history we can make it out. And patient usually insists that the blood pressure elevation is not related to emotional distress. So in history, careful history can differentiate between the both. Paroxysmas characteristically begin abruptly and can last minutes, hours, or even days. The paroxysms often provoke a marked fear of imminent death or stroke. The fear follows rather than precedes the onset of physical symptoms. That is altogether different in labile one. Fear of recurrent symptomatic paroxysms can lead to restriction of lifestyle and function. Some more differences can be seen here. The panic disorders, episodes of fear or panic that are commonly associated with physical symptoms such as chest pain, headache, palpitations, flushing, and dizziness, along with some degree of blood pressure variation. So if you find all these symptoms which are associated physical symptoms, then probably we are dealing with panic disorder. Greater severity of emotional distress and the prominence of the physical symptoms, that is the hallmark of the panic disorder, and primarily complain of anxiety or panic. Why this difference is required? Because the treatment is altogether different. And you can very well see here what I was talking about, the hypothalamo-pituitary adrenal axis, and that is shown here at the level of amygdala, various sensory cortex, and all the sensory stimuli reaching to there, and we know that all type of sensory stimuli ultimately reach to hypothalamus, and they can be special senses, they can be normal senses, they can be even emotional type of stresses, all they reach to hypothalamus. In response to that, hypothalamus secretes various hormone-like substances or hormones which are hypothalamic hormones. They are called as releasing factors or inhibiting factors. They go to anterior pituitary, and anterior pituitary has different type of cells, and the corticotroph cells secretes ACTH, and ACTH secretes from the corticotroph cells, and the ACTH goes to adrenal cortex, and in the adrenal cortex it releases a lot of cortisol. So that is one by which the all impacts of panic disorder are seen. Do we really need to treat episodic hypertension? Why we are bothered? If it is episodic, can be left alone? But that is not the case. You can see here, reduced risk is there, but not very high risk. But still you can see the stroke is about nearing to the increased risk. So the treatment is required, visit to visit variability and CV outcome is shown. So if the visit to visit variability is high, then definitely increasing the risk. And short-term blood pressure variability and some organ damage. See here, the organ damage in cross-sectional and longitudinal studies have been shown that the organ damage has a clear-cut relationship with the short-term blood pressure variability. So more variability, more organ damage. So it requires any degree time of variability is a risk for organ damage. Whether it is short-term has been studied well, but even the long-term do have that, and any degree and time of variability is a risk for organ damage. Therapeutic strategy. When we have diagnosed it, how we can treat it? Management considerations are choice of therapy for the underlying chronic hypertension and treatment of acute episodes of blood pressure elevation. There are two things, and managing chronic hypertension untreated, start with guidelines which are recommending first line therapy, and we know that one pill, either it is ACE inhibitor plus calcium channel blocker or diuretic. So initially now we know that most of the time dual combination is started, because most of the time single drug is not enough. So the combined pill FDC is used in most of the time, either ACE inhibitor or ARB, combining the CCB or diuretic. Most of the time considering monotherapy in low risk grade 1 hypertension, that we know most of the guidelines agree are in very old, more than 80 years, are the frail patients, we use only monotherapy. Although most of the time we require two drugs. In step 2, when triple combination is used, the combination of CCB, ARB is combined with diuretic. So 3 drugs in one pill. So FDC again, and 2 pills are required in step 3. Triple combination plus 1 spironolactone or other drug is given when it's resistant hypertension. That is very well known, and this particular guideline we are following for the management of blood pressure, and we start the spironolactone with a dose 25 milligram and goes up to 50 milligram. If not controlled, then we use other diuretic or alpha blockers or even beta blockers are given. Consider a referral to a specialist at this particular time, referral to a particular blood pressure specialist, hypertension specialist, because sometimes resistant hypertension requires a very thorough investigation. Beta blockers are definitely given most of the time, and especially in the Indian population, and with their specific indication, compelling indication like heart failure, angina, post-MI, atrial fibrillation, or younger women with are planning pregnancy. Chronic hypertension, we know that uncontrolled and treated, again ACE inhibitors, CCB, the same thing which I was talking about. Beta blocker is added or alpha blocker is added, and non-lipophilic beta blocker is preferred over the traditional beta blocker, and we know that at present, most of the time, these non-lipophilic beta blockers are being used. Controlled and treated ACE inhibitor, CCB, do not aid beta blocker and alpha blocker. If required, substitute on the agent with beta blocker or alpha blocker, and alternatively, acute episodes should be treated. Acute episodes should be treated differently. So, whatever we will be talking based on clinical experience, there is no major published data available for managing the episodic hypertension. Medicines, beta or alpha blocker, which one is superior choice? Difficult to say. And different patients, different drugs have worked well. Nephrogenic factors are important there. Sympathetic factors are important. And definitely when the sympathetic factors are more important than beta blockers will function better. They trigger in episodic hypertension, and blood pressure variability and heart rate can be one particular aspect which can differentiate between them. Beta blockers can be combined with alpha blockers or alone should be given. These are some important lessons. Sometimes only beta blocker is enough, but sometimes we have to combine them. Beta plus alpha blocker combination can be given, and in some patients this works nicely. And cilindipine dual, both L and N blocker. Because we know that the newer CCBs have this property that they can block not only L-type calcium channels, they can also block N-type calcium channels and T-type calcium channels, on the basis that cilindipine can be used, vinidipine can be used, azilidipine can be used. Whether ARBs are to be given or ACE inhibitor to be given, again, this is a very, very debatable question, and we know that most of the ARBs are having robust decrease in the blood pressure, while ACE inhibitors are not that potent in reducing blood pressure, but they have their own benefit, and some ACE inhibitors are very potent even, and clonidine sometimes can be given. So, acute therapy of episodic hypertension, I was talking about the chronic one, that drug will continue, but for the acute episode of the blood pressure had to be dealt with some other drugs. And sometimes these things are very, very important, because do not treat with a chronic antihypertensive therapy unless more frequent exposure. Meaning by that, in episodic acute therapy must be given only for acute purpose. One should not start the chronic antihypertensive therapy in all the patients unless there are more frequent episodes are there. Counseling is more important, reassurance is important, and reassurance that it is extremely unlikely to cause a stroke or other sudden cardiovascular event, advised to avoid repeated murder. This is very, very important. I have seen in my practice again, and you all have noticed that most of the patients respond that every half an hour they measure blood pressure and say, "Doc, my blood pressure now have gone to 220, now it has gone to 230, now it is 180. So this has to be discouraged. No, not a hypertensive emergency. You have to reassure them it is not an emergency. If the blood pressure remains high for a very long time, then only you can have some complication. Not a single episode can produce any complication. Treat symptomatic patient with substantial psychological distress. That had to be done. Most of the time, psychotherapy and sometimes anxiolytics and antidepressant drugs can also help. Pharmacotherapy in acute episode can be in the form of start-acting antihypertensive agents, and benzodiazepines are the drug of choice, and most of the time patient thinks that they are the drug for hypertension. And if the patient is coming to you with a history that, "Doc, I'm taking this pill and you find that it is alprazolam or etizolam, you can diagnose clinically that most probably the patient is having episodic hypertension. That is why he's taking the etizolam or the benzodiazepines. Beta blocker labetalol has been used when episodic hypertension remains for some time, and typically 100 or 200 milligram orally can be given. Clonidine is a drug which is given 0.1 milligram orally, can be used in episodes, acute episodes. Alprazolam usually goes 0.25 milligram orally, SOS, on the episodes of acute episodes. Antihypertensive versus benzodiazepine. You have to find out clinically that which patient require only benzodiazepine, which patient require antihypertensive drugs. If you find that only benzodiazepines are not reducing blood pressure, then you have to add the antihypertensive drugs for episodes as well. But before going for the chronic antihypertensive therapy, you have to evaluate the patient again and again. Pre-procedural blood pressure elevation is very, very common, and for this particular purpose, traditionally we are using benzodiazepines and also alpha blockers and beta blockers. They have been used. Most of the time, before any interview, any viva, medical students are very fond of using propranolol, non-selective beta blockers, and that is very old phenomena. In most of the hospitals, you will find a lot of propranolol. So I will summarize that episodic hypertension is widespread and is a common problem, specialist referral. However, because of the absence of defined criteria for episodic hypertension, there are no data regarding prevalence. Indian data are not. Recurrent and substantial transient elevation in blood pressure, that is very, very important. Frequently, but not always, have systolic readings above 160 milligrams per day. Sympathetic nervous system involvement in blood pressure, reactivity to environmental stressors, that is a common pathology. They become more reactive to same environmental stressors which may not have any reactivity in other populations. More likely to occur among NCS patients and patients under acute stress. Counseling and anxiolytics works better rather than any antihypertensive drug, because if you advise drug, the patient will develop hypertension. So you have to be very, very cautious. Any degree of variability associated with poor cardiovascular outcome, treat when needed with benzodiazepines, alpha blockers, beta blockers for chronic management. Acute episode had to be treated by alprazolam, labetalol, or clonidine, depending upon the type of the patient. So with this, I will like to end. Thank you. Thank you very much.
Thank you, Professor Verma. That was an exhaustive review on episodic hypertension. We have several questions. We'll take it at the end of second talk by Dr. J.C. Suri. And now I invite Dr. Suri to talk about sleep disorders and hypertension. Dr. Suri, as I already told you, Director and Head of Department of Pulmonology, Critical Care and Sleep Medicine at the Fortis Hospital, Vasant Kunj, New Delhi, and he has been a former professor and head of Department of Pulmonology at Vardhaman Mahavir Medical College and Safdarjung Hospital, and he has more than 1,000 publications, national and international journals. He has been the editor-in-chief and publisher of the Indian Journal of Sleep Medicine, and who better to talk about the relationship of sleep deprivation, the sleep disorders and hypertension than Dr. J.C. Suri. Floor is yours, Dr. Suri.
Thank you, Dr. J.C. Mohan, the course director, for giving me this invitation. Thank you, organizers. Let me share my screen. Okay, good evening, everyone. Today I am going to talk about the importance of sleep in cardiovascular health, and particularly with reference to hypertension. As you all know, sleep is an integral part of our life. We spend 1/3 of our lifespan sleeping, so it has to be very important. Sleep is very essential for our mental health, physical health, and emotional health. So, what I am going to talk today is that when we talk about sleep, then we also talk about good quality sleep. So, what do we mean by good quality sleep? Good quality sleep does not mean only the duration. That means one has to sleep for 7 hours, 8 hours, or 9 hours, but it is also the continuity. That means sleep period should be seamless without any fragmentation, and then the depth, because we know that sleep is a heterogeneous period. We have non-REM sleep, we have REM sleep. In the non-REM sleep, we have stage 1, stage 2, which is the light sleep, and then we have stage 3, the deep sleep, REM sleep. So there is a percentage of each type of stage which is represented into what we call as good quality sleep. So we should have enough representation from all these stages. And lastly, a good quality sleep also includes the timing. Timing means it should be in sync with the circadian rhythm. That means if you are sleeping with your planet, that means when it is dark, when it is night, then you are sleeping, and when it is daytime you are awake. So you know, people who are on shift work, there are people who are studying at night and working or sleeping during the day. So if your sleep is not in sync with the circadian rhythm, with the environment, then also it is not considered to be a good quality sleep. So when we are talking about sleep, we are talking about insufficient sleep. That means when the duration is less than what it should be ideally, and also the continuity, what we call as the fragmented sleep. So sleep fragmentation and sleep deprivation, they often occur together. And what we mean by sleep fragmentation is when it is characterized by frequent arousals. And symptoms caused by sleep fragmentation are similar to those caused by sleep deprivation. So that's why we are actually discussing them together. So we cannot differentiate or uh, separate sleep fragmentation with sleep disruption and sleep deprivation. Wherever there will be sleep fragmentation, there is going to be sleep deprivation for this thing. So the symptoms which we normally see in patients who have sleep deprivation or disruption are increased objective sleepiness, decreased psychomotor performance, which we usually see by vigilance test, reaction time, short-term memory, and of course mood disturbances are very important component of sleep deprivation and sleep disruption. Consolidated episodes of sleep which should be exceeding 10 minutes are required for sleep to be restorative. So there are situations, you know, where you may have an arousal every minute in the sleep. So that kind of a sleep with so many arousals, which is so fragmented, is not supposed to be fragmented. So minimum period of consolidated sleep is 10 minutes. The more the period of consolidated sleep, the more restorative it is in its quality. Now, why we should think that sleep deprivation or sleep disruption should be associated with hypertension and other cardiovascular disease? To understand that, we should first know what are the normal cardiovascular changes in sleep, that is both in non-REM sleep and REM sleep. When we go to sleep, as against wake state, there is a significant drop in the sympathetic activity and increase in the parasympathetic activity. And with this increase in the parasympathetic activity, there is a consequent decrease in the blood pressure and heart rate and cardiac output, and there is also decrease in the ventilation and metabolic rate. So sleep is considered to be a period of cardiovascular quiescence. So this cardiovascular quiescence, that means when there is a fall in blood pressure, when there is a fall in heart rate, then there is at least uh, fall in 10% of blood pressure during sleep. So this is what we call as nocturnal dip. There is a period in REM sleep, when during REM sleep, we have two phases. One phase is we call it tonic REM, and the other is the phasic REM. The phasic REM means when you have rapid eye movements, and the tonic REM is the REM sleep without rapid eye movements. So when there are rapid eye movements, there is a increase in the sympathetic activity. So during that part of REM sleep, you have increase in the blood pressure and increase in the heart rate. So normally, the whole sleep period should be considered as parasympathetic dominant period, which is associated with cardiovascular quiescence and a dip in 10% of blood pressure. That's what this thing. Now, what happens when we develop arousals, sleep fragmentation? And I will take the example of obstructive sleep apnea to use it as a prototype to describe the impact of arousal on our physiological system. And you can see here, this is a polysomnograph where this is the flow. Here the patient is breathing, and then the person stops breathing here. And this is what is called obstructive apnea. And this apnea is terminated by a cortical arousal. You can see there is a arousal here. And during this apneic phase, you can see that there is an increasing effort to breathe. So this is the esophageal pressure here, which we monitor, and you can see the effort to breathe increases, and this effort has increased, to something like minus 20, minus 25 or 30 centimeters of water before the arousal may occur. Although this arousal threshold may vary from person to person, and there is also a significant dip in the oxygen saturation. So what we are seeing during sleep apnea is an intermittent hypoxia and then reoxygenation. So it is the intermittent hypoxia followed by hyperventilation phase where actually the oxygen level goes up. So you develop hypoxia and then hyperoxia. So the damage which the patient gets is not only due to hypoxia but also due to hyperoxia with the release of oxygen radicals. So intermittent hypoxia and reoxygenation and recurrent arousals, with sleep fragmentation. As you can see, this is one arousal, this is another, and there is an exaggerated negative intrathoracic pressure, as I have shown this thing. So what is the impact of this? The impact or the consequence of this is sleep deprivation because of the repeated fragmentation. There is sympathetic activation, and there is also pro-inflammatory state due to this intermittent hypoxia and hyperoxia. So intermittent hypoxia but not sustained hypoxemia achieves inflammatory pathways, and the inflammatory pathways lead to the development of endothelial dysfunction and atherosclerosis, which I am not going to discuss today because today's talk is specifically referred to the impact on blood pressure for this thing. So the most important thing for the development of hypertension is increase in the sympathetic activation. And what is the evidence for that? And this is the evidence here. You can see that again the person here, this is the flow, this is the apnea. Their apnea is terminated. Again apnea, and patient breathes, and you can see the fall in oxygen levels here. And what you can see here is the blood pressure. So you can see that with each episode of apnea, once the apnea is terminated, there is an increase in the blood pressure. So with each apneic episode, there is fluctuation in the blood pressure, and this blood pressure goes up and down. And this increase in blood pressure is associated with the increase in the sympathetic activity. As you can see, this is a peroneal nerve monitoring of sympathetic activity. So this is the integrated sympathetic activity. So this is what you are seeing, that obstructive respiratory events are associated with increased sympathetic activity, as you can see it here, and rise in the blood pressure, as you can see it here. Now this increase in the sympathetic activity is not only present during sleep, as I can show that it is with the increase with each episode of apnea, but there is a spillover effect of this increased sympathetic activity over the daytime. So this is what you can see during the awake period here. If you compare the sympathetic activity of a normal person who does not have sleep apnea and a person who has sleep apnea, you can see that there is a marked increase in the sympathetic activity in obstructive sleep apnea patient even when they are awake, that means during the daytime. And this you can also see with the increase in the urinary norepinephrine level. Here you can see that this is as the severity of sleep apnea increases, more and more apneas, more and more arousals, more episodes of sympathetic surges, you can see that there is an increase, corresponding increase in the urinary norepinephrine for this thing. So this is, the bench evidence that if you see in the laboratory, if you study a patient of sleep apnea and you see when they have multiple arousals, there is an increase in the sympathetic activity, and that is why we believe that this person should be having high blood pressure. And that was the basis for starting various observational studies, various longitudinal studies, and various interventional studies to see the cause and effect relationship between obstructive sleep apnea and hypertension. So here, if you treat these patients of sleep apnea with CPAP, there is a clear evidence that CPAP is associated with significant decrease in the sympathetic activity, in these patients. So the more number of hours when you are using the CPAP, that significant percentage decrease in the sympathetic activity what you are seeing here. So this can be seen very nicely on this 24-hour blood pressure recording. Here you have two group of patient. One is the sleep apnea patient, which are represented in the red dots, and the controls in the blue dots. So you can see this is the upper one is a systolic blood pressure and the lower one is a diastolic blood pressure. And then you can see, first we will see in the controls. So in the controls you can see that this systolic blood pressure here, so this is the clock here and this is the sleep time. So this is 1 to 7 or 24 to 6, whatever it is, this is the sleep time. And you can see that there is a significant dip in the systolic blood pressure in the normal control, and similarly there is a significant dip in the diastolic blood pressure in the normal control. But what happens to patients with sleep apnea? In patients with sleep apnea, you can see this dip in the systolic blood pressure is far less than what you see in the control. So this nocturnal dipping disappears. So if you are doing 24-hour blood pressure monitoring in a patient with obstructive sleep apnea, you will not be able to see this 10% dip in the systolic as well as the diastolic blood pressure. So same happens with the diastolic blood pressure. You can see that during sleep, as compared to the controls, the diastolic blood pressure does not fall as comparison to the daytime blood pressure. So it is almost very close to that. And the another very important thing is that in patients of sleep apnea, during daytime, the diastolic blood pressure is much higher than the controls. Although there is not much difference in the systolic blood pressure between the sleep apnea patient and the control, but here you can see that the diastolic blood pressure is significantly high, and this corresponds with the increased sympathetic activity during the daytime, as we have demonstrated, increase in the urinary noradrenaline secretions, urinary secretion of noradrenaline, and that corresponds with this thing. So OSA is associated with the recurrent arousals and sympathetic overactivity, which results in non-dipping pattern. So this is a very strong, physiological or pathophysiological basis for us to believe that these kinds of patients should have high blood pressure on long-term basis. And similarly, when somebody has a sleep deprivation, and during sleep deprivation, we know that there is a decrease in the leptin and increase in the ghrelin hormone, and this results into increased appetite, patients eat more, and then with the development of obesity, they have increased cortisol, increased sympathetic activity. Why there is this increased sympathetic activity? Because sleep is a period during which there is a parasympathetic dominance. So if you sleep less, significantly less, that period will have sympathetic overactivity. So that's why the overall impact of sleep deprivation may be similar to multiple sleep disruptions. So there is a significant increase in the sympathetic activity, and this may result into increased 24-hour blood pressure. So we have a very strong, very robust pathophysiological basis for patients who have sleep deprivation or sleep disruption to have high blood pressure on a long-term basis for this thing, you know. So now I go into the evidence, you know, evidence from various studies which have been conducted on the basis of this pathophysiological foundation which was created. And then, you know, the first thing comes to our mind is that if sleep deprivation can cause hypertension, are people getting enough sleep? So what is the status of sleeping pattern? What is the status of number of hours people are, in general, people are, you know, sleeping and this thing. And if you see here that in United States, you know, this is the data from National Sleep Foundation, that about 37% of all adults report sleeping less than 7 hours per night. And this is much more in patients, you know, who are younger, who come from low socioeconomic status, and, you know, those deprived categories. And the trend suggests that short sleep increases over time. And a meta-analysis of almost 7 lakh children from across the world suggests that in the past century, the sleep duration has decreased by 0.75 minutes per year. You know, so as our society is growing, as we are becoming a 24-hour society, the sleeping hours are gradually getting constricted. And this is one study which we conducted somewhere in 2018 in Delhi school children. And what we found, we defined sleep deprivation for children who are sleeping less than 8.5 hours per night. And what we found that in 11 to 12 years category, 83% of the children were sleep deprived, and 13 to 15 years, 90%, 90 to 92% are sleep deprived. So the older adolescent, lesser sleep, and we found higher depression in them. And we could not study at that time the prevalence of blood pressure because it is a questionnaire-based study. And we of course did some sleep studies in selected patients and those who were considered to be having obstructive sleep apnea. The long-term effects of chronic sleep deprivation has been now seen in large number of observational studies and also bench studies. And we know that chronic sleep deprivation is associated with increased automobile accidents, increased morbidity, mortality, coronary artery disease, high blood pressure, obesity, type 2 diabetes, stroke, cancer, memory impairments, and depression. So it has a much wider impact, you know, on the body and every system, because sleep is a period of physical and mental restitution. And it is practically every organ system, all organ system of our body undergoes complete restitution during the sleep period. And if this restitution is not complete, so all these diseases of regulation gets affected, and you have metabolic derangements, you have blood pressure irregularities, and you develop, coronary artery disease, and you have mood disorders, depression, cancers. All these things are now becoming much and more common. And this is a very important, prospective study, what we call the EPIC study in Europe, where they have tried to find out an association of sleep duration with chronic disorders. So now, what are these chronic disorders? They were diabetes, hypertension, myocardial infarction, stroke, and cancer. And you can see here, that there is a significant increase. If you look into the hazard ratio, it is becoming more than 1. So as long as people are sleeping for 7 hours and more, the hazard ratio is less than 1. And once your sleep hour goes below less than 6 hours, you can see that there is a significant increase. So the participant with less than 6 hours per day of sleep has 30% increased risk of developing overall chronic diseases, which I have just mentioned. And there are other studies, which have been done for different conditions like hypertension, coronary artery disease, diabetes, and impaired glucose tolerance. And you can see here again, this is a study which was conducted in 2006 for hypertension involving 4,800 patients. There was an increase in the risk of hypertension for people who sleep less than 5 hours. And similarly also, there is an increased risk of coronary artery disease, acute MI, diabetes, and impaired glucose tolerance, all in patients who are sleeping less than 5 hours. This thing. So this is a recent study. This is the beauty of this study is that it is a longitudinal study. So where they have taken people who have no known hypertension, they don't have any cardiovascular disease or metabolic disorders, and then they have followed them over a period of time. It's a longitudinal study, and they looked into the incident hypertension which developed in people who were sleeping adequately and those who were not sleeping adequately. And this study clearly shows, in this large study, young and middle-aged women and men, what they found that individuals with either considerable changes in sleep duration or persistently short sleep were at an increased risk of new onset incident hypertension, underscoring the importance of maintaining moderate sleep duration to prevent hypertension. So this is I think a very important and a strong evidence, because it is a longitudinal study. It's not a cross-sectional study. And then after discussing about deprivation, now I'll be talking about disruption or the sleep fragmentation. And we know when the sleep fragmentation occurs due to repeated arousals. And these arousals may increase during sleep as we grow older. The sleep disorder breathing or sleep apnea, obstructive sleep apnea, central sleep apnea, they are frequently associated with repeated arousals. Periodic limb movements disorder, restless leg syndrome, again you have a lot of arousals. Neurodegenerative conditions which we see, Parkinsonisms, and then other the neurological sleep disorders like narcolepsy. They are also associated with this thing, increased arousals. Insomnias, as we know, it is difficulty in initiation of sleep or difficulty in maintaining sleep. So if you are not able to maintain sleep, that means you are repeatedly getting up from the sleep. So you have a lot of arousals, and of course poor sleep environment. And then patients with medical disorders, people having congestive heart failure, with paroxysmal nocturnal dyspnea, other types of breathlessness, COPD, when patients develop repeated episodes of hypoxemias, so painful conditions, all these cause repeated arousals, and these arousals should be associated with increase in hypertension. So I'd just like to mention some evidence for this. So age, again, you see, as you grow older, your arousal index starts increasing, and you can see, when you have 21.9 arousal per hour, so that means practically every 3 minutes at the age of 61 to 70. See, imagine at the age of 61 to 70, a normal person who is not supposed to be having any problem will be waking up, will be having an arousal index of 21 plus minus 6. That means if you take 20, that means every 3 minutes. So as I mentioned to you, you need to have at least a consolidated period of 10 minutes to have a restorative sleep. So these patients then become more vulnerable. So that's why the incidence of hypertension increases with age, and because one of the factor could be the sleep fragmentation increases with the age in this patient. And then we talk about the prevalence of sleep apnea, particularly in various situations. If you take hypertensive patient, 30 to 60% of the hypertension patient have sleep apnea, as against normal population, it is significantly more. If you look into the resistant hypertension, patients who are requiring more than three or more than three antihypertensive drugs and to control their blood pressure, 80 to 90% of them will be having obstructive sleep apnea. So it's very, very important to pick up these patients of resistant hypertension and evaluate them, for sleep disorder breathing. And because what we have seen, in studies, there is a significant improvement in their blood pressure once you detect and treat obstructive sleep apnea in these cases. So the evidence for sleep apnea causing sleep disruption and hypertension, I think this is the most important study, which is a cross-sectional study, from Wisconsin cohort, and you can see that as the sleep apnea, severity increases, as you can see, the incidence of hypertension the odd ratio of developing hypertension increases. So this is no obstructive sleep apnea. Odd ratio is just 1, and once a person has mild, moderate, severe, very severe sleep apnea, the odd ratio goes beyond 1, and this is there even after adjusting for other confounders like age, sex, and ethnicity and BMI. So this continues. So you have increasing. So there is a dose response. So in a cross-sectional study, you have increased prevalence with reference to control, and then with increasing severity of sleep apnea, you have increasing odds of developing hypertension. That means there is a dose response curve. And then if you have longitudinal study, the same Wisconsin study, these patients who are followed up for 4 years, and you try to look for the new onset or the incident hypertension. Again, it was much more in patients of obstructive sleep apnea than you found in patients with the normal control. Again, this is a study here. You can see this is a 15 years follow-up study, and here you are looking into the cumulative incidence or the new onset hypertension over a period, and you can see that as the severity of sleep apnea increases from mild to moderate to severe, when these patients are followed up over a period of time, the new onset of hypertension incidence increases with the severity of this thing. So this is a good observational study, a long-term observational study, which clearly shows the relationship between the severity of sleep disorder, breathing, and the new onset hypertension over a period of time. This thing. The resistant hypertension, as I mentioned to you, hypertension continuing despite more antihypertensive drugs, and in this, this study found that 96% of the men and 65% of the women have obstructive sleep apnea. So these are the people who are taking 3.6 drugs. Their BMI was 34, and this is another. You can see here, again the patients with these are the patient AHI more than 10, and then AHI here again you can see control subjects, and these are the patients with resistant hypertension. Again, you can see 71% of the patients have obstructive sleep apnea, as against 38% in the control group. So this is another very interesting study here, where they are looking for the risk factors for resistant hypertension. So we commonly see, the risk factors for resistant hypertension. One is the age, gender, BMI, and also the duration of hypertension. But if you see that all these factors, there is no significant, impact on development of resistant hypertension, whereas patients who have sleep apnea, more than moderate sleep apnea, you can see that their odd ratio is almost 4.8 for developing resistant hypertension. So obstructive sleep apnea is one of the most important risk factor for developing resistant hypertension. So sleep apnea not only can cause hypertension, because as we will see on the intervention study, which improves hypertension, it also makes the control of hypertension worse. That's very, very important thing. And we know that blood pressure control is one of the most important preventive aspect for preventing long-term cardiovascular diseases. So this is a systematic review and meta-analysis, where it has been studied that if you control the blood pressure below, at least by 10 millimeters of mercury, what impact it has on prevention of long-term cardiovascular morbidity and mortality. And here you can see very clearly that if you decrease the blood pressure, and this is for each 10 millimeter reduction in systolic blood pressure, there is a significant drop, in the cardiovascular disease and death. So it's a very important thing that we should control blood pressure. And if sleep apnea is one of the important factor in the genesis and in the worsening of control of hypertension, then it should be detected and treated in these patients. And there are now interventional studies, and I think randomized control trial, the interventional trial of treatment of sleep apnea on the reduction in the blood pressure. Probably this is the highest level of evidence we can have, and we have seen that most of the RCTs, have resulted into drop in the both systolic blood pressure as well as diastolic blood pressure, though the amount of blood pressure drop was relatively less, but it was both statistically significant and also clinically significant in terms of reducing long-term cardiovascular morbidity and mortality. So these are the multiple meta-analysis here. You can see where which shows there is a drop in systolic and diastolic blood pressures, and these are all you can see, and the drop here you can see is from 1 to 3 millimeter. So there is a 1 to 3 or 4 millimeter drop in systolic, and then 2 to 3 millimeter drop in the diastolic blood pressure. In various meta-analyses we have in this thing, and this is what you see in resistant hypertension. So in resistant hypertension, you can see the drop can be to the tune of 8 to 10 millimeter. It is centimeters of water, I think millimeter of mercury here. You can see, there is a significant drop in this thing. So what we see from these various RCTs, from meta-analysis, the effect of CPAP on hypertension is that CPAP significantly reduces blood pressure, similar in both in males and females. So once we have, through these interventional studies, a significant drop, this establishes a cause and effect relationship between obstructive sleep apnea and hypertension. And we have also seen in the 7th report of Joint Commission on Prevention, Evaluation and Treatment of Hypertension report, where sleep apnea has been mentioned as one of the secondary causes, avoidable causes. In the list it is mentioned now. And CPAP, we can see, it reduces. But in these things we have found that it drops 2 to 2.5 millimeter systolic blood pressure, 1 to 5 to 2 millimeter in diastolic blood pressure, but there's much greater reduction in 4.7 and this thing in resistant hypertension. Although it may look that this drop is very small, but it has been seen that it is associated with 4 to 8% reduction in the future risk of strokes and coronary heart diseases. And these are the studies where there have been a lot of limitations in measuring blood pressure. There were limitations in the compliance of treatment used for monitoring blood pressure. So I think what it has been seen that if you take a subgroup of patients who have severe disease, severe sleep apnea, the other limitation why this fall has been less is because many patients were taking antihypertensive drugs also. So that may have also somehow confounded the effect of CPAP in these patients. So the subgroup of patients who have severe disease, those who have resistant hypertension, those who have better compliance with CPAP, and those on antihypertensive, we have something like more than 10 millimeter fall in both systolic and blood pressure. And this could reduce the risk of coronary artery disease and stroke by 37 and 56% respectively. So this is a very, very important thing. And now I go to the other causes of sleep disruption. One is, of course, the insomnias. It was also mentioned by my previous speaker. So what it shows that even if you have one night of disturbed sleep, only single one night of disrupt sleep, it can actually result in significant increase in the blood pressure. So the study is yet to be published, but this shows that if a patient can have a spike in blood pressure with one night of disturbed sleep, and if a patient has long-term chronic insomnia and chronically disturbed sleep, then these patients will have a much higher risk of heart attack, stroke, and even death from cardiovascular disease because of the increase in the nocturnal blood pressure. Another conditions like periodic limb movements disorder in sleep and restless leg syndrome, because these PLMS, what we call PLMD, where PLMD means when it is a disorder, that means these leg movements are associated with arousals, and with the arousal there is sympathetic surge, and this has been associated with high nocturnal blood pressure values, and particularly in patients with insomnia. So the result of this study shows that PLMS are related to increased nocturnal blood pressure values in patients with insomnia, which may partly explain the relationship between insomnia and hypertension. Therefore, it is possible that treatment of PLMD may normalize nocturnal blood pressure in patients with insomnia. So this is a very important finding. Again, another periodic limb movement in sleep are followed by increase in the EEG activity. This because of the arousal, there is an increase in blood pressure and heart rate variability. Again, the results suggest that PLMS are followed by arousals, related nervous system events, and given the high frequency of PLMS throughout the night, where the PLMS index can be maybe 20, 30 or 40 per hour, then they could be a potential risk factor for nocturnal arrhythmias and hypertension, in addition to causing sleep deprivation. So there is always a combination like this, and other neurological sleep disorders which are associated with blood pressure, and this was a review, and in this review the authors have discussed the potential pathophysiological mechanisms underlying elevated blood pressure in restless leg syndromes, periodic limb movement of sleep, sleep-related bruxism, narcolepsy, cataplexy, and rapid eye movement sleep behavior disorder, what we call the REM sleep behavior disorder. And they have also examined the relationship between these sleep disorders and elevated blood pressure, and the impact of treatment of these conditions on blood pressure. So these are the important evidences, which we have seen in the recent past. So I will end my talk with this important take-home message, that it is very important to pay special attention to the sleep quality of patients with hypertension, like you are doing. You're looking into the dietary habits of the patient, you're looking into the salt intake, you're looking into the fluid intake. So it is also now very important to pay an attention to the patient's sleep quality, both in terms of sleep deprivation and sleep disruption. And although we have now a clear-cut evidence of cause and effect relationship between sleep apnea and hypertension and response with CPAP therapy, the link between other conditions, like PLM, periodic limb movement disorders, and insomnia, this is not that strong, because we don't have yet high quality randomized controlled trial. So the research needs to be done to understand the impact of other disorders of sleep, which cause sleep disruption and high blood pressure. Several types of sleep issues can cause hypertension, as we have mentioned, or either they cause hypertension or they will make it harder to control. So these are usually sleep deprivation, when a person is sleeping less than 6 hours, obstructive sleep apneas, insomnias, PLMDs, and restless leg syndrome, and other neurological sleep disorders. And by identifying them, by evaluating them, and by treating them, we may be able to benefit many patients of at least resistant hypertension, and help in decreasing their long-term morbidity and mortality. Thank you for your kind attention.
Thank you, Dr. Suri. That was a very good review about sleep disorders and hypertension in general, and sleep disorders with lifestyle diseases in particular. And we have understood a few things. Number one, sleep disorders will continue to increase over a period of time in this society, because now you have social media, you have television, and you have all these kind of things. So sleep, the overall, I think next 30, 40 years, if you're talking about, the duration of sleep will fall further. I'm pretty sure it's not going to be 7 hours as you would like to be. It is going to be, it would fall slowly, it will keep falling, and the average sleep hours probably 10 years down the line you might see at 5.5 hours rather than 6.5 hours of now. So that is a major challenge, which actually means certain disease which will increase in prevalence, which will be hypertension, obesity, diabetes, And of course, cancer has been related now with that, depression, and many more things which will be related. There is no doubt about it. Third important thing is it probably is one of the simplest ways of managing many of these lifestyle disorders if we are able to take care of the sleep. The hypertension part probably is as far as the fall in blood pressure is concerned, while taking care of his obstructive sleep disorder, they probably what has been a kind of disappointment in general, both from randomized trials and from meta-analysis. But I think more work needs to be done. A given patient may show 10 millimeter fall in systolic blood pressure, you rightly said, but we have extensive meta-analysis, and as cardiologists, we have seen that the fall in systolic blood pressure on ambulatory blood pressure monitoring, at least in hypertension about 2 or 3 millimeter, and in resistant hypertension about 4 and 5 millimeter. That's the average, and that has been a big disappointment. We could discuss that issue, but to comment on both these things, we have our two experts, and our first expert is Dr. Manish Bansal. Dr. Manish Bansal is Director of Clinical and Preventive Cardiology, Medanta, the Medicity, and he is one of the foremost echocardiography specialists of the country, and currently the editor-in-chief of the Journal of Indian Academy of Echocardiography with numerous publications. A lot of work on strain imaging, an area which of course is also closer to my heart. And I would ask Dr. Manish Bansal to comment actually on the first topic, but let's introduce to you Dr. S.M. Ashraf, who is Professor and Head Department of Cardiology, GMC Kannur, and he has a large experience in teaching cardiology, good number of publications, and of course, he is an accomplished intervention cardiologist. I would ask Dr. Manish Bansal to comment on the first presentation with regard to episodic hypertension. What are your views, and is the management primarily should be with drugs or with antipsychotic drugs or so-called antidepressant, anti-anxiety drugs, and of course lifestyle modification? And do you believe that the maybe moxinidine, which is short-acting, could also be used in some episodic hypertension? Dr. Manish Bansal.
Yeah. Good evening, everyone. See, the topic Dr. Verma discussed in his presentation is something which we encounter every day. And he very rightly mentioned that the patients keep checking their blood pressure every hour, every 2 hours, and they panic and they rise in blood pressure. And this is something which is very, very rampant. Now, regarding management, I feel, which I regularly do, two things are very, very important. First is good counseling. Patients need to be told that blood pressure is not treated SOS. It's not that you take extra pill if blood pressure goes up, you drop one pill if blood pressure goes down. That must be avoided. Baseline treatment should be continued without any change. Only when blood pressure is sustained elevated or sustained low that we make any changes in the chronic drug therapy for hypertension. And the other thing is that anxiolytic. I think I use them routinely. I think they are very, very helpful in taking care of these episodic increases in blood pressure. In fact, to most of my patients who ask me that, doctor, when blood pressure goes up suddenly, which antihypertensive? I tell them that first of all, do not panic. And if you're really worried, take clonazepam or whatever medication that I want to prescribe at that point of time and monitor blood pressure. If it is elevated persistently, then come back to me. I'll tell you what to do. And I also tell them that yes, beyond this level, which is generally very high level, that is a time when complications may occur acutely also, and then they need to report. But rise in blood pressure by 20-30 millimeters of mercury in systolic or 10-15 should not be resulting in any panic or panic reaction from the patients.
is a pretty good way of shortly describing the whole thing. The reason why this is important is, as you rightly said, in real life it is a big issue. I actually just 10 days back had a 70-year female with severe aortic stenosis, whose daughter will give me a ring at exact midnight saying our blood pressure 170 by 110. And every day, next morning she'll come, the blood pressure bloody 120 by 60, 120 by 70. And repeated. I got an ambulatory blood pressure monitoring done repeatedly. It's absolutely normal, daytime, nighttime. But of course, once in a while there's a big peak. And I can only do reassurance. But more than that, actually, that lady is causing me episodic hypertension because she gives me a ring every midnight. Why do you check blood pressure at midnight? You should bloody. So I said, don't check your blood pressure. And I agree with Dr. Verma. Don't repeatedly check your blood pressure. But there are some people who keep checking their blood pressure every 2 hours and they have this problem. Absolutely rightly said.
One more point I would like to add. While we we say that episodic hypertension needs to be treated with reassurance and sometimes anxiolytics, it is also very important that we use proper therapy for chronic hypertension in these patients, long-acting drugs, effective treatment. Otherwise, if you are using short-acting drugs or ineffective treatment, that will lead to significant BP variability. And in that case, patients are not unjustified in raising that issue.
Yeah, I think we need to actually understand that short-acting drugs like losartan, like valsartan, like hydrochlorothiazide, like ramipril, actually, if you want to give them, give twice a day.
Yes.
And this is a major issue. People writing Covance B, and of course, these people have more episodic hypertension. What can you do about it? We know it. And so that is why you rightly said, the ESC says the first thing is for essential hypertension, give longest possible acting antihypertensive drug. So you have a very right point. Dr. Ashraf, we'll switch gears. I want you to comment on the sleep disorders and hypertension. There are plenty of questions from the audience, but this is an area of extreme importance. I think the two are so much coupled, and as Dr. Suri showed, 80 to 90% of resistant hypertension having obstructive sleep apnea. Obviously, this couldn't be the only cause. They probably are not causally related, but they run parallel. They're running like the two tracks of the train, actually. And I don't know how much, and of course, we would discuss that issue, but I want your comments on that, that presentation, plus your personal views about sleep disorder and hypertension.
Thank you, sir. Dr. J.C. Suri made extensive, exhaustive coverage with sleep deprived hypertension. In my practice, it is routine to do the sleep study for all resistant hypertension patients, and also inserts that one slide showing a lot of things, association like hypertension, diabetes, cardiovascular disease. But he mentioned about the arrhythmia part. But I want to make one more comment that very commonly associated disease like atrial fibrillation, the initiation and the maintenance of that atrial fibrillation is not dependent on obesity or hypertension, independent risk factor. So all AF patient is the patient in the age group without any secondary cause like valvular disease, atrial fibrillation, you had to exclude the obstructive sleep apnea part, and that will respond to your CPAP therapy. And the slide showing whether CPAP will improve all these cardiovascular events, definitely yes. And they consistently show decrease in the hypertension in between the normotensive and hypertensive group. Suppose you have a hypertension group 1 arm and normotensive arm with a CPAP treatment on OSA. The hypertensive arm has shown biggest advantage. There will be both daytime hypertension decline and also nighttime. So I think should be a routine practice to check those who are having 3 antihypertensive drugs to get the sleep study. Those with atrial fibrillation, definitely you have to check for the sleep study. And even obesity is not a factor for the OSA. Many of the time there will be some sort of OSA without much BMI, body mass index. So, or high index of suspicion is needed.
Okay,
and I just want to add the initial one, the the first one, that hypertension part, episodic part, even though people are talking very lightly on the episodic part, but as a in hospital treatment, sometimes episodic come in other department. For example, patient already trauma in a ortho case, they will come with a barrel reflex failure sudden. So when you suspect mean that the sudden rise in BP of 220 and 90, then with a 100, then suspect, you have to suspect the barrel reflex issue, and you should be very cautious. You should not give too aggressive, only for short, very short acting. Just like that, in post-operative cases, BP will be around 200. Don't be aggressive. You can accept up to 180 systolic and 110 diastolic post-operative, early, perioperative and post-operative. So these are two clinical scenarios I just want to add for the those who are working in a secondary center.
So Dr. Ashraf, I want to be devil's advocate, and I would say, since OSA occurs in 80 to 90% of resistant hypertension, why do the study at all? We just presume it. Just presume it. If it is 90%, just presume it. Number one. Number 2 point. In resistant hypertension, we have the biggest randomized studies that Spanish Sleep Network, in fact, and is by, I think, Martinez Gracia. And that is studies named by Hipparco. In fact, I have been very fond of this study. That had just a 3 millimeter fall in systolic blood pressure in 1,100 odd patients of resistant hypertension who were on 3 or more drugs and still not controlled. Why at all worry about doing an OSA and giving a CPAP for blood pressure control if I am going to have 3 millimeter fall in systolic blood pressure on average?
But sir, absolute reduction will be 3 to 5 millimeters. But the issue is when the BMI reduces, for example, if your BMI reduces less than 10% in a resistant hypertension, there will be other comorbid conditions like diabetes and obesity, hypertension. And the thing is that in a patient with OSA, if you are giving CPAP therapy, some people may not be even non-responders. 20% may not be non-responders to CPAP therapy. So this just like even that the CPAP therapy will improve the declining effect of the antihypertensive therapy. It is not the absolute reduction. It actually improves the antihypertensive drug medication efficacy.
No, I am actually disappointed. I will tell you why I am disappointed. I always believed that the CPAP is a pretty good way. When initially in 2011 this Hipparco came, I was a little disappointed. But of late, actually, I have seen two meta-analysis, one purely in resistant hypertension, and that is by Dr. Liu and his colleagues, and another is in all hypertension, some 23 studies by Dr. Fu and his colleagues, and both studies have the same thing. In regular kind of hypertension, the fall in systolic blood pressure is 2.5 millimeter, systolic, 2.5. And for resistant hypertension, it is 4.8 millimeter. So my point is actually, isn't it too big an effort?
No, sir. It is because it is the AHA index is correlated with the resistant hypertension. For example, if the AHA index is more than 40, that means severe AHI, there will be more associated with severe hypertension. So many of the patients may be mild.
So we'll get back to Dr. Suri, but I want to tell you an interesting thing. Few weeks back, actually, the Harvard Medical School published a data which they said AHI is not a predictor of rise in blood pressure. It is AHI plus FEV1 less than 90%. When you combine the two, only then you get some significant, at a p-value, statistical significance with regard to predicting who is going to develop hypertension. Very interesting data actually from Harvard. With AHI alone is not the culprit. With AHI, abnormal pulmonary function is probably more responsible for future development incident hypertension. Let us ask Dr. Suri what are his views. I mean, we cardiologists, of course, don't know everything about that, and we'll ask Dr. Suri to make a final comment.
I think this, which you have just given, is something we get, repeatedly from most of the cardiologists, and that's true also. What you are saying, I cannot directly say that what you say is not correct, but I would like to put forward certain points, which I think needs consideration. First of all, our fundamental basis, the pathophysiological basis and bench studies are very strong to suggest that sleep apnea is associated with hypertension, and treatment of sleep apnea can reverse hypertension. And this I can tell you on animal experiments. When you create artificial sleep apnea and then you see the blood pressure going up within 2 to 3 months, and then you treat the sleep apnea because you add some nasal obstructions or this thing, and then you remove it, the blood pressure normalizing. So we have strong this thing. Then we have data for sympathetic activity, sympathetic surge, and those things which are very strongly suggestive of blood data and this thing. We have very good observational studies also. We have good dose responsive longitudinal studies also. And the most important evidence, which when you say that cause and which will establish cause and effect relationship between sleep apnea and OSA is interventional study, RCT interventional study. And what we have found that in these, the patients which have been taken are first of all very heterogeneous. The group of patients which we have taken, they have a large number of different mild, moderate, severe. Some are on ambulatory blood pressure, some are on office, the blood pressure taken like that, So there are a lot of variation in the methodology. Number of cases in individual RCTs have been less. Then the most important thing has been the compliance with CPAP, And if you do the subgroup analysis between those who are with good compliance using for more than 5 hours, 6 hours, 7 hours, because this is one parameter which would directly depend on the number of hour usage of CPAP. And I want to tell you here is that the REM sleep, which comes predominantly in the last part of sleep. The last 1 to 2 hours our sleep is REM sleep, and that is the time we have the worst sleep apnea. And a sleep apnea which is REM sleep predominant has a very high incident hypertension, and many of the patients who use CPAP would remove their CPAP in the last 1 hour or 1.5 hours, and with the result, that benefit which one has to have with CPAP, the most benefit by using CPAP for the whole period of sleep is lost. And if you go into the average CPAP compliance in most of these trials, it is something between 3.5 to 4 hours, which is again, means that the treatment is subtherapeutic. It is not very effective. The another thing is, as you mentioned, resistant hypertension, because there are, if you see the study and if you look into the confidence interval in that, so you will see a lot of people having 10 millimeter. Yeah. You are talking of the average or the mean value, which is coming to 4.2 or 4.5, as against normal hypertension, which is 2.3 or 2.4. But if you look into the confidence interval also, it's quite wide, and there are many patients of resistant hypertension where there is a more than 10 millimeter drop in blood pressure. So that many of these patients are treatment naive. They have not been on antihypertensive drug. So that way, because if suppose you have a patient of severe hypertension, where probably you also have severe sleep apnea, which is not only causing but also making it worse to control. So if you give 3-4 antihypertensive drugs, then probably you have exploited the antihypertensive capability of drugs to the maximum, and there is little for CPAP to do in such situation. The best part in these studies would be that after starting CPAP, whether we have been able to withdraw the drugs, how many drugs we were able to withdraw, and this thing. Because most of these studies are of 3 months to 6 months duration. It is a very short period for any treatment to become effective and to understand the role of CPAP. The another thing which I want to tell you, that hypertension is not a simple disease. It is not sleep apnea and hypertension. There will be very few patients where secondary hypertension, where sleep apnea is the only factor. hypertension has so many other determining factors, and sleep apnea may be one of them. And in many situations, apnea may be only a contributor, not the sole factor causing for this thing.
This is exactly what we were discussing.
In a situation like that, if you are using CPAP, the response is going to be less because it is a contributor, only maybe 10%, 15%, depending upon its severity and also the duration. The last part which I want to mention here is that there may be structural changes in the vasculature due to long-standing hypertension. And if you have a patient of resistant hypertension or a long-standing hypertension where arteriosclerotic changes have already taken place, irreversible changes have taken place, where you see, very high systolic blood pressure, diastolic pressure is low. No, in a situation like this, the CPAP probably may not be very effective because it's a long-standing. And another thing is that to get some meaningful benefit with CPAP, you may have to, I think, follow them up for a much longer period of time, ensuring also that they use the CPAP for whole night, covering the REM sleep of the early morning. And we do not have at present any such study to tell us that if you use CPAP. So I still feel that we do not have an evidence. Whatever evidence we have, which is sketchy, patchy, and not very good, it shows, that kind of results. But what I feel, the pathophysiological mechanisms are very strong. You have to select your patients where you think, the sleep apnea is a major factor or a predominant factor, where you see the disease is very severe and other factors are not there, say obesity is not there, and other, dietary factors, genetic, strong family history, so many things. If you select, because it is a syndrome. Hypertension is a syndrome. It is not one single disease. So I think in the evaluation, you have to look for such patients, and those patients are the one, who come into that. When you see the confidence interval, 2 standard deviation, they are the one, who are going to give you a very good response. So you have to see, and also those patients who are symptomatic, those who have excessive daytime sleepiness. So there are many patients of hypertension with sleep apnea who do not have sleepiness. So you cannot, patient is not, is forced by a disease to take treatment because he has no symptoms. So he says, why should I take treatment? If you ask them, you have snoring, he say, I'm not bothered about snoring. Maybe my wife is more bothered than me. So I don't know. I sleep very well. I wake up very well. I don't feel sleepy at all. And even when he has an AHI score of 30 to 40. And again, this AHI is not the gold standard metric now. So what we want to know is what is the pathophysiological mechanism responsible for hypertension. Now we are coming, it is the degree of desaturation, oxygen desaturation. So now we have even phenotypes in OSA. So there will be subgroup of OSA phenotypes who have symptoms, who have a very excessive oxygen level desaturation, low oxygen, very, very low minimum oxygen saturation. They are the one, who are likely to respond to CPAP better. They are the one who are likely to have a much bigger drop in blood pressure. So what I finally, in sum and total, I want to say that we have to pick up from the phenotypes of OSA, the one who is more likely to be where the OSA is a predominant factor and is more likely and severe and is more likely to have good result. And on the other hand, we also have to pick up from the phenotypes of hypertension, where you think that this kind of secondary factor, risk factor may be much more prominent, and where this thing. I think once we start having studies with that kind of approach, then definitely you will see a good response, a subgroup of patients who are going to respond very well to CPAP therapy.
So I think the conclusion of what you have said is we have to better characterize responders.
Yeah.
We somehow need to characterize people who have OS and hypertension who would be responders or hyper responders.
Yes.
I completely agree with you, and
yes,
it is, I think, a very valid point. I was mentioning about this work which came out of the Harvard, they correlated the AHI with the hazard ratio for incident hypertension, and the correlation was very poor. They also tried to look at duration of sleep by hours and the hazard ratio for incident hypertension. Again, the correlation was poor, not reaching statistical significance. But the moment they added FEV1 below 90%, things started becoming better. So what I think you are absolutely right. We need to characterize our patients better. Somehow, this is one way of characterizing. This is not the only way. You rightly said, even amongst hypertensive, maybe you have to see how much desaturation, how long desaturation, what is the severity of desaturation, is it regular or person gets it once a while? Many things which we need to see. Dr. Verma, you have any comments on this issue?
The whole thing has been very good, very nicely summarized by Dr. J.C. Suri and yourself. I do agree that in every patient the cause may be different. So sleep apnea alone may not be responsible for that, but definitely having the good sleep and creating the atmosphere for good sleep. A few studies we are doing by implying dream. Dream is a new methodology to know about sleep study that is very, very new. And that also encourages for the good quality of sleep. And that has shown that there is some decrease in the blood pressure, maybe not very significant, but that has shown. It is very early to comment on that, but in the coming time, I think the data will be there.
So let us now take questions from the audience.
Yes,
we'll start from the last question. The last question says, can we use SGLT2 inhibitors in resistant hypertension? Who would like to make a comment?
I was just thinking about this. Dr. Suri gave real pearls about the connection between sleep apnea, CPAP, and hypertension management. I was just wondering, it is also equally important to address obesity in many of these patients rather than blaming CPAP for not working. Because if the person's lifestyle is bad and not losing weight at all, there will be many other factors. And the way SGLT2 inhibitors have been showing benefit in so many different phenotypes, and now in HFpEF also, it won't be surprising that they turn out to be a good therapy for this also.
So, Dr. Kenneth Ferdinand, who was the past president of American Society of Hypertension, in Circulation, actually 2.5 years back, roughly, published a study of resistant hypertension and empagliflozin and ambulatory blood pressure monitoring. And he showed a mean systolic blood pressure fall of 7.8 millimeter in resistant hypertension, where no other drug was changed except SGLT2 inhibitors were added. But remember, these were all diabetic individuals. So you are very right. Maybe more than CPAP, SGLT2 inhibitor can cause almost twice that blood pressure fall, largely because you are losing weight, you are losing sodium, you are losing water, you are losing visceral fat, your sympathetic activity goes down. As somebody said, that the SGLT2 inhibitor do decrease sympathetic activity. The work maybe through hypothermal pituitary adrenal axis or maybe any other way, but the sympathetic activity, there is some data to suggest that MSNA activity goes down when you use SGLT2 inhibitor. Absolutely right. I would agree. Let's take the next question. The next question is, how will you manage episodic hypertension? I think we have discussed this issue already. We have discussed that issue already in reasonably good detail. Let us take the other quickly and take the other questions. And okay, any comments on treadmill test for diagnosis of episodic hypertension?
Sir,
Dr. Ashraf.
Basically, like any other physical activity, we expect the blood pressure, both systolic may go up, and we often, if there is hypertension, is an abnormal response. So the exaggerated hypertensive response is a early indication, definitely, because sir already mentioned that when the patient going for, even for the exertion, there is labile hypertension is seen more than 20 minutes of mercury. So in abnormal response is an early indication patient is and hypertension. And actually, hypertension you have to track from early childhood, like even adolescent age group. Actually, even from the neonatal life. Suppose patient, the low birth weight patient nephron mass will be less, and you track from the early childhood and adolescent group, and we are missing so many hypertensive school kids. So those kids are going for exertion related symptom. We have to check the BP and see any abnormal response. And of course, there is no need of TMT response to see the hypertensive response. But it's normally we usually check during treadmill test the blood pressure response.
So about 6 days back, actually, I was asked to give a lecture on mask hypertension. So I thought I will look at treadmill and hypertension business in greater detail. And we found that if the blood pressure response is exaggerated, which means if the systolic blood pressure crosses 170 on treadmill, then you can predict mask hypertension with a sensitivity and specificity of about 70%. I was impressed. I don't know about episodic hypertension being predicted, but I found that very interesting data actually, and I thought I'll bring to your notice. The other interesting thing which might interest you as well as Dr. Verma and everybody else, recently there is a study from Morocco, and what they have done is try to treat people who have episodic hypertension or labile hypertension or the blood pressure which is uncontrolled in office space at home, but not in the doctor's clinic, and they gave barbiturate to these people. And now it is a randomized study, beautifully conducted, small dose of barbiturate, and they were able to show blood pressure reductions which actually were as much as 40 millimeter of mercury with barbiturate. So I would ask you to say, Dr. Verma actually I say, and Dr. Manish Bandha said, I think barbiturate does make a lot of sense. I mean, I would not have thought of using barbiturate in somebody who has this kind of repetitive episodic hypertensive episodes. But these Moroccan guys went ahead and they did a study and they showed that you can control, because barbiturate works through all that axis which Dr. Verma talked about, the hypothalamus, the locus coeruleus, and of course medulla oblongata and all everywhere else actually. So interesting. Let me see if there is any other question. Otherwise, I think we need to wrap it up. We are already 2 hours. What is the difference between episodic hypertension and white coat hypertension? Dr. Verma, last question and we are ending it.
Yeah. Sir, I think that was already discussed, but again highlighting that episodic hypertension and white coat effect is entirely different. The only connection is that the adrenaline drive or the sympathetic drive. That is the only connection. But white coat effect is a known definite phenomena which is present in every patient, and that can easily be separated, because in the office setting, in the home setting, and blood pressure taken by the doctor, by the nurse, by the attendant, the white coat effect is a definite phenomena which can be taken care of. But the episodic hypertension is entirely different. So I don't agree that they are same.
Yeah, no, they're not same, but somebody wanted to make a distinction. Distinction is very clear. Episodic hypertension can occur anywhere.
Yeah, anywhere.
At home, at work, at night. But the white coat hypertension, peculiar phenomenon when healthcare providers take blood pressure, or sometimes your wife takes your blood pressure can shoot up. Of course, those are exceptions. There are, of course, strong wives who can have WCH effect actually. But nevertheless, I think the episodic hypertension, you rightly said, is a different thing. And I know we could discuss this subject on, and it interests all of us, but we have to end it. Many of you are waiting for your dinner. I will ask Dr. Mithilesh Nayak to come in and Amit Arora to come in and try to wrap it up by thanking our esteemed experts and our speakers.
Thank you, sir. I would like to thank you because you have a wonderful topic to everyone, and the discussion actually took it all. And we had approximately 1,300 doctors from across the country who have joined in today. And I think there were a large number of questions which were answered during the discussion, I suppose. And as Dr. J.C. Suri said, that it's a syndrome, and it has so many facets to be discussed. And I feel there are so many more episodes are going to come for hypertension, which are going to be brought to you from Team Zenith in TAS. And I must thank all of you, all the delegates who have attended today. I thank Dr. J.C. Suri for his lecture, Dr. Narsingh Verma for consenting to be part of this program. You are very busy, sir. And I must thank Dr. Manish Bansal and Dr. S.M. Ashraf for being able panelists today to discuss these two very important topics. So thank you very much from our side at INTAS. And we are a leading player in calcium channel blockers. Silni is our cilnidipine, MTAS M, which is amlodipine metoprolol, and MTAS 80, which is amlodipine atenolol. So these are drugs which we make for hypertension. So we look forward to your support for these drugs. So thank you very much once again here at INTAS. Over to you, sir, Dr. Mithilesh, and thank you very much once again. Good night to all of you.
Thank you.
Yeah.